There we go. All right. Good afternoon, everyone, and welcome to June's Diabetes Prevention and Management Community of Practice. Thank you all for joining us today. I did put in the chat this session will be recorded. And next slide. So during today's session, this is a brief agenda. We'll be going over some brief introductions and a fun icebreaker. We'll follow that up with an overview of the diabetes landscape assessment results. We'll then move into discussing the diabetes prevention and management community of practice goals and upcoming curriculum for July 2025 to June 2026. And we'll get feedback from you all in an open discussion. And so I'll go ahead and I'll pass it over to Tyler to get us started. With our introductions, actually, please include your name, title, and organization in the chat so we can all know who's here today.
Okay. Hello, everyone. So my name is Tyler. I'm going to give us the icebreaker for today. So if you had a chance to pick a go-to healthy snack that helps you manage your energy or blood sugar throughout the day, what would it be and why? Feel free to share in the chat or come off mute if you feel comfortable. Mariana, I can't see the chat, but is there any answers in the chat?
No answers on the chat. Oh, we got fruit and nuts.
Okay, that's a good one.
Some raw almonds is a healthy snack. I like it. And with the fruit nuts. Oh, a protein shake?
Same.
Protein shake. I like doing the my like morning overnight oats, putting the protein in there as well with some chia pudding, yeah.
I love a chia pudding too.
Fruit or trail mix.
Okay.
All right, nice.
All right, I will go to the next slide. Um, okay, so the purpose of the diabetes prevention and management landscape assessment, um, we the purpose of it was to gather information on active diabetes education sites in the district for our landscape maps for 2024 and 2025. Through 2024 to 2025. Next, we want to understand successes and challenges experienced by diabetes education and prevention educators. We want to also provide technical assistance to diabetes programs. And we also want to identify ADA, ADCES, and CDC recognized accredited programs and assess other programs' accreditation readiness. So I will now go into the implementation process of our landscape assessment. The landscape assessment was implemented in two phases. Phase one was July 2023 through June 2024, and phase two was implemented July 2024 through June 2025. Um, the organizations, the organizations that we have, well, I'll show you that on the next slide. So, Um, the tool that we used for the landscape assessment was the Microsoft Forms survey. We did our outreach strategies comprised of emails, calls, in-person visits, and warm connection handoffs from our partners. We were able to reach 3 out of the 5 ADA recognized DSMES programs and 6 out of 6 ADCES accredited DSMES sites and 2 out of the 6 CDC recognized DPP sites. We were also able to reach non-accredited sites, so we gathered information from 2 diabetes prevention education sites and 4 self-management education sites. These were the organizations that completed the landscape assessment. The organizations that have a red check by them are the ones that are either ADA or ADCES accredited. I can give you a little time to look at it, see if you recognize your organization, if it's here. Um, we also decided to show results on the accessibility of programs. In order to ensure accessibility to these programs, we wanted to identify and address any potential barriers to participation. So that is including transportation, how the program is delivered, program cost, and awareness of the program. We assisted through these four categories. So for the first one, it is transportation. For DPP programs, one program offers transportation incentives, and two are metro slash bus accessible. And for DSMES, one program offers transportation incentives, and 12 of the programs are accessible by metro or bus. And then we have delivery for DPP. One program delivers hybrid sessions, and another program delivers virtual sessions. For DSMES, 8 deliver hybrid, 2 deliver virtual, and 2 deliver in person. And then next, we look at the program costs. Two programs for DPP have a fee, and for DSMES, 3 programs have a fee and 9 programs do not. We also looked at the awareness and the visibility of the program on LinkU. And as you can see here, YMCA is claimed on LinkU, and what it means to be claimed on LinkU is it basically indicates that the program has a designated person to manage the program listings. So kudos to YMCA for DPP. And then we have for DSMES, we have Sirogi. They are claimed. And then we have Belima Pharmacy, Grubbs Care Pharmacy, Grub Southeast, and Colorama. In the next program year, we're going to really try to make sure that everyone has their program claimed. And then we have programs reached by wards. Our priority programs or our priority wards are 4, 5, 7, and 8. So for Ward 4, we have one program that is DPP CDC accredited, and then we have one program that is accredited for DSMES, and then we have one non-accredited program for DPP, and then another one that is non-accredited for DSMES. And then when we look at Ward 5, we have 2 accredited DPP programs and 3 accredited DSMES programs. We have 0 non-accredited DPP programs and 1 non-accredited DSMES program. Ward 7, we have 2 accredited DPP programs and 5 accredited DSMES programs. We have 0, once again, for the non accredited, and 1 non accredited DSMES program. And lastly, for Ward 8, we have 1 DPP program that is accredited and 4 accredited DSMES sites with 0 non-recognized DPP and 3 non-accredited DSMES programs. And we also identified key themes in the landscape assessment as well. So the first one was funding and financial support. People who or organizations that completed the landscape assessment were asking about grants or insurance reimbursement options. Um, and another way to look at reimbursement options is mandating adequate payment from MCOs. Next, we have education and promotional support. So that looks like providing Spanish education classes for diabetes and nutrition, developing promotional materials, and assisting with the accreditation process. Lastly, we have assisting with transportation services and stipends for clients and increasing referrals to DSMES and DPP programs through clinic and community partnerships.
Thank you, Tyler. Can you all hear me?
Yeah, we can hear you.
Okay, perfect. Thank you. So welcome everyone. Some of you are newer to this space. Some have been here for some time now. I'm going to start with an overview of the community of practice and then go into the curriculum that was really informed by the landscape assessment that Tyler just covered, as well as some other programmatic findings from this year. So about us, the diabetes prevention and management community of practice convenes key stakeholders across clinical, community, and pharmacy settings with the aim of expanding access, visibility, and sustainability of high quality diabetes prevention and management services in the district. The community of practice serves as a collaborative learning environment to share best practices, overcome implementation barriers, and foster innovation across the diabetes care continuum with the goal of improving diabetes health outcomes. Next slide, please. Next slide. So we use 5 overarching strategies to drive the work in the community of practice. That's facilitating cross-sector collaboration and communication, promoting the adoption of best practices in diabetes care, centering community voices and lived experiences. So there's a real opportunity for this strategy for us to grow and improve, support sustainable programs and interventions, and track and improve health outcomes through data sharing. Next slide. So our next programmatic year goals for the community of practice are to increase the availability and visibility of diabetes, of DSMES and other diabetes management support services in high need areas. So Tyler just went over how many programs are available, where they're available. One caveat to note is that some of the program sites, some of the programs identified do have multiple sites. So that is something to note that'll be reflected in our updated map. We also want to support the launch, growth, and sustainability of DSMES and diabetes support programs across clinical and community settings. We want to build pharmacy-based capacity to deliver culturally responsive diabetes self-management, education, and support services, and engage hard-to-reach populations. And lastly, foster peer learning, technical assistance, and collaboration across a multi-sector network of providers and partners. Next slide, please. So our curriculum, we're really looking forward to getting your input on this as we work together to create a roadmap that's going to inform the COP for the next year. So each year, the COP will be supported by a data-informed curriculum. This year, again, it came from the landscape assessments and other programmatic findings. We'll focus, from that, we've decided to focus on expanding the availability and accessibility of evidence-based diabetes education and support services across clinical, community, and pharmacy settings. So we're going to change the structure a little bit this year. I know many of you are used to meeting every month. So we're going to now meet every other month. So the cadence is going to change. We'll meet every other month with one in-person meeting per year. We're looking at, since November is Diabetes Awareness Month, we're looking to have our in-person meeting coincide with that. And then every other month, we'll have Pharmacy Wellness Hub technical assistance calls. So this will really be a space dedicated to our pharmacy partners to standing up and sustaining these programs in pharmacy settings. And those will be alternating months. Next slide, please. All right, so we will have for the full diabetes prevention and management COP meetings. Again, these will be 6 sessions every other month. We've divided the curriculum topics across 3 themes, informed by this year's findings. So these are building referral pathways, increasing cultural competency, and billing and building billing capability. So for building referral pathways, we're going to have start off with a kickoff and map the referral landscape. We'll then follow with a session on building strong referral networks and leveraging EHR. For cultural competency, we'll have a session on increasing appropriateness and feasibility. This session will likely be in person, and in-person meetings is really a space where we like to engage residents and persons with lived experiences. And, you know, we thought it would coincide well with this topic as we're looking to ensure that our programs are culturally competent. Next session will be implementing peer-led SMRC programs. So these are evidence-based lifestyle change, chronic disease self-management programs, diabetes self-management programs in community settings. Billing and building capability. So we'll have a reimbursement 101 for DSMES programs, followed by a session on data tracking for referral and billing improvements. Next slide, please. Next is the overview of topics for the Pharmacy Wellness Hub calls. We'll really focus on increasing enrollment and retention in pharmacy-based programs. We'll start off with DSMES and pharmacies, getting started, licensure, workflow integration, reimbursement basics, followed by engaging pharmacy staff in delivery, role clarification, training, and delivery of care models, marketing DSMES in pharmacy settings, outreach strategies to increase visibility and uptake. Then we'll have documenting outcomes in pharmacy-based DSMES, tracking impact and meeting quality standards. Next, reimbursement deep dive for pharmacies, becoming billing capable, Medicare billing codes, private payer contracts, and Medicaid updates. And lastly, pharmacy innovation showcase, which will be a meeting, an opportunity for our pharmacy partners to highlight their innovative diabetes care programs and models. Next slide, please. Right. I'll hand it over to Mariana quickly before we go into the feedback on the curriculum.
Sure. Thank you, Shannon. So Shannon mentioned we'll be moving to a new meeting cadence. We want to get your input and we want to know how you are all feeling about having this meeting right now, as we currently do on the 4th Tuesday of the month at 2 p.m. So I have an open poll here. And you all can begin to put in your selections. You don't have to select just one. You can select multiple. I did exclude Mondays, but if you feel strongly about Mondays, then go ahead and let us know in the chat. And I'll let it run for about a few seconds here. We'll give it like 30 more seconds. And so far I have the Tuesdays. Afternoons are good, looking good still for everyone. Okay. You have about 10 more seconds. Any specific requests, please feel free to write them in the chat. And it looks like Tuesday afternoons are winning. You might keep it. Okay, Looks like we'll be keeping Tuesday afternoons. All right, thank you, everyone.
Great, thank you. That was nice and easy.
That was great.
Yeah.
That was really easy.
Right, next slide, please. All right, so from your feedback today, it's an opportunity to be open, honest about your needs to ensure that the, again, curriculum for the year reflects that. So we'll analyze any trends in the feedback that we received today. We'll again review our current curriculum and identify gaps and opportunities and incorporate the feedback that we receive into the curriculum to ensure that it reflects the needs of our partners. Next slide, please.
Okay, everyone. For my favorite part, I'm actually very excited about this because this is a new tool that we're using. I'm going to have everyone, I'm going to put this link in the chat. Let me stop sharing my screen for a second. I'm going to put a link in the chat for our data collecting tool that we're using. Hold on. If you have problem accessing it, just let me know. But okay. Wait, that's okay. Here we go. And let me share my screen again. Okay. Can everyone see my screen? And also, does everyone have access to the link? Is everybody able to access the link? If not, you could put your answers in the chat. But for this activity, we are asking 3 questions. What do you think is missing from the curriculum? What would you want the goal to be for the COP program year of 2025 to 2026? And thinking about friends and family and residents you serve, what makes the diabetes education more accessible? So for this tool, you will go into sticky note if you're able to open it. And just click on any color sticky note and you could just add what you think under each of these questions. And yeah, just so we could just get a better understanding of what you guys think about the curriculum, what you would like to see more of. And yeah, I will give everyone about how long? Maybe like 3 to 5 minutes to complete it. And like I said, if you're not able to put your or if you're not able to access this or you're not in the space to click on this link, just put it in the chat. But yeah, and we can all just do like a live, of what everybody thinks.
Tyler, can we see can you reshare the curriculum slide again?
Sure.
Thanks.
Um, mm, 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 mm. Can everyone see?
Yes, thank you. We'd also love to, as we talk through the curriculum, get your input on suggested speakers for the topic. So feel free to drop that in as well.
Mm, 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 mm. I seen that someone just joined the meeting. Um,
Yeah, we can give an update on where we are.
okay.
Mhm.
So, I think it's Tamara. I think you just joined the meeting. Mariana, do you mind copying and pasting the mural link back into the chat? Those who just entered, we're asking for you to use the mural platform and add a sticky note to answer the 3 questions at the top about our DPM co-op curriculum for the year of 2025 to 2026. So feel free to add in the chat or add to the sticky note. Um, yeah. I'm seeing a couple of
Oh, mhm.
you have something that you had something, Shannon?
Oh, yeah, I was just going to give Dr. McCants a quick update. So we went over the diabetes prevention and management landscape assessment that was performed, as well as some of the key findings that we use to inform the development of this curriculum. Um, the goal for next year is to expand accessibility and availability of DSMES and other diabetes uh, self-management support services in priority populations. And so we'll move from a monthly meeting cadence to now every other month as a full COP convening. And these are the 3 themes and corresponding topics for those 6 sessions. In alternate months, we'll have our pharmacy wellness hub, where there's a separate curriculum or list of topics dedicated to standing up and sustaining these programs in pharmacy settings. We can look at that slide also.
Okay.
Okay, Dr. McCants has a firewall. Yes, I will email it to you.
Okay. Shannon, should I go over what I see in the little sticky notes so far?
Yes, give me, are folks ready to reconvene? Are we still working? Dr. McCann, so sending the link over. Let me get a yes, no, proof of life.
I think they're still working. I see a lot of little
Okay,
cursors
good.
just going around. So,
Right. Let's see here. Okay, just sent that over.
Okay, I'm going to give everyone about another 30 seconds. If you have not already completed it. Okay, I'm going to do another 15 seconds because I see somebody typing as we speak right now. Okay, so we can go over what we have so far. So I see someone typing for what do you think is missing from the curriculum? I see patient engagement.
Yes,
Um,
it's me. I'm sorry. I don't know if you could do it like a different color or something, but it's me and I'm late, so I don't want to hold it up. So,
no, you're fine. You're fine. If you wanna speak more, if you wanna like explain your answer, you can do that too. Don't, yeah. I really wanted this to be like an open discussion.
okay, well, I'll start. So thank you for sharing this. And of course, I just looked at it really quickly. I wasn't aware of any discussion. This is probably what you all talked about. But the reason why I'm saying that this is missing from the curriculum is because sometimes we think that just because we have a good program and it has good intention that people are just going to come, but that's not the case. If anybody is on the line that has ever established or tried to implement any patient facing program, especially for patients that are hard to reach, quote unquote. So I think that the curriculum is missing, or what we could probably include more in the curriculum is just patient engagement strategies. So what do we do when a patient doesn't have the right telephone number, or they have several different numbers, or you know just how do you convince them that just recognizing that sometimes it's going to take 3, 4, 5, 6 conversations for people to get engaged and be involved in it. So I just don't want us to take that for granted, and I do think that there's something that we may want to take a little bit of more time in the curriculum just based on my initial glance.
That was really useful feedback. I definitely think, definitely as public health professionals, because we focus on everyone, we are very zoomed out. So to, have strategies to increase patient engagement, I think that that would be really helpful. Um, I see there's no more, if anyone has any responses for number one, you can come off mute or put it in the chat. Um, but on the sticky note, there's no more answers. For the next question
I
is,
see,
oh,
sorry, Andrea, expanding DSMES Medicaid coverage in DPP.
okay.
Yeah.
Hi, Andrea Troutner here. Can I just briefly share my comment?
Yes.
Sure.
Okay, so I am currently a DSMES instructor for serology. I'm also the ADCS grassroots coordinator for Maryland coordinating body. And there came up an ask by the members of ADCS Maryland coordinating body, what are we going to do about DC Medicaid coverage for the District of Columbia and Maryland? And I know that your sole mission is DC, so that's why I bring it out here in this forum as to, are we even aware of the barriers that we cannot offer DC Medicaid insurers this benefit? And they need, you know, that profile most likely could benefit. I'm also president healthcare consultant for my own business. So I just do DSMES as a self-pay because I am not an accredited or recognized program. I have been an accredited or recognized program for Providence Health System 8.5 years. So I understand what it involves. So my task or my ask or my charge for this organization is not to look the other way, not that I'm saying you are, but to really do a deeper dive as to why we are allowing this barrier with DC Medicaid participants to continue to carry on. I also have been a DPP organizational charge. Providence rose to a Medicare diabetes prevention program supplier, and we got full plus recognition. So I know all the nuances of how hard it is to run programs, but unless you understand reimbursement and offer all reimbursement to all insurances, you know, we're going to have you know, some that can benefit from it and others that can't, unless we constantly rely on some type of grants. So is this is a huge ask of these participants, and I'm having my first work group meeting with a combination of educators who are a whole realm of different scopes of practices, from RDs to pharmacists to nurses. And, you know, we may decide after tonight's meeting that it's just not worth our time. We have too many barriers ahead of us. But I do have the ADA collaborator on my side. I do have ADCS on my side. Is this something as a work group, you all, that you think you would want at least be a collaborator with this work group? That's my question. And two, was this work group today even aware that DC Medicaid it doesn't cover DSMES, and I don't even think it covers DPP. I am not talking about the managed care organizations for DC Medicaid. They cover medical nutrition therapy, but that's all they cover too. The DC Medicaid gets neither MNT, medical nutrition therapy, from a registered dietitian, nor do they get DSMES. And it's been going on way too long. And I know that this subject we have to tread water very carefully because of the cuts in Maryland and because of the budget cuts in DC. It's probably the worst time to even advocate it, but we all know the evidence is there. It saves money. So maybe this is an opportunity for us to put ourselves out there. So I'll stop now. I probably overextended my welcome.
No,
but I'm really passionate about this, and it's very aggravating to sit here and listen to some of the barriers where I think we're missing, you know, a wonderful opportunity as educators. So
yes. So to answer your first question, absolutely, we would love to be in that work group, in that space. And I think you bring up a good point, Tyler, Mariana, on incorporating the work that we are doing with healthcare finance on Medicaid coverage for DPP and DSMES, and bringing that into the space, at least updates and really identifying how we can leverage the COP to move that forward. I will say we have, so the Department of Healthcare Finance in the district, which oversees Medicaid, recently transitioned leadership, and we have their new medical director is an absolute champion, and has expressed her commitment to ensuring that district residents will receive district Medicaid beneficiaries will receive access to DPP and DSMES. We also participated, DC Health and Healthcare Finance, in a public health, Medicaid strategy work group together. It was a multi-session work group where we identified strategies, drafted shared commitment language, and really solidified their buy-in. So we do have that. The biggest barrier really is budget. And that right now we have to, so there's tons of data supporting the clinical and financial impact of evidence-based programs like DPP and DSMES. What our healthcare finance office is asking is to see, and we have done this before, but sometimes when you have new leadership, they want things done a little differently, and so they're asking to see it demonstrated in their in the Medicaid population in a budget neutral way. So so that's what we're working with them on now, and we'll be rolling out over the next year. The work that we're doing with our pharmacy partners will also contribute to that data that they're asking for. And so, yeah, we can more explicitly call out that work and provide more regular updates on that. Absolutely, because that is something that is a priority for the DC Health team, and it is something that we're continuing to work towards. Kind of full disclosure, it's just taken like longer than I or we anticipated. Sometimes it feels like 2 steps forward, 1 step back, especially when you get new leadership. It's kind of like starting over. So that's where we are. But there is momentum, and we are moving in that direction, and that is a priority for us.
Thank you, Andrea, for sharing. We really appreciate that. Really all the information that we can get, all the opinions, all the feedback. So thank you.
Thank you.
I think, I mean, I feel like we kind of hit 1 and 2 already. Because I don't know if I can't see the chat, but if there's anything in the chat that addresses 1 and 2, you can come off mute. But if not, for the next question, or last question, is thinking about friends and family and residents you serve, what makes diabetes education more accessible? Does anyone want to come off mute, or should I show the answers that are on the sticky notes?
I can talk about what I input. This is Isha, Dr. Winfield. I've talked about this with you all like in other settings, but on the site I put both in-person and virtual options. I think when I started the program that we are supporting at Grubbs Pharmacy, in my brain, virtual meant more accessibility for everyone. I do think that virtual expands the accessibility, but I feel that in some settings, especially since COVID, we have removed in-person interactions and solely focused on virtual, not even realizing that though it expands it to some populations who are able to use the virtual options, there are many people who still either prefer it for their engagement, whether it be their ability to understand and follow the information, or some people just do not know how to navigate technology. So by removing the in-person options, we then limit our touch or our reach to people who have access or are able to navigate the virtual options. So I think that opening our brains back up to in-person options and how we can make those things happen for our residents would allow for more individuals to benefit from the programs that are being put in place.
Thank you for sharing.
Mm-hmm.
I definitely agree. Because I do think that virtual was helpful, and a lot of us are adopting or have adopted like virtual learning or virtual work. But, for some people, it just doesn't work, especially if you have like those technology literacy barriers. So, yeah, thank you. Thank you for sharing. Um, did anyone else want to share? Can we go back to yes? I'm not sure who said that, but it just popped up on my.
Yes, this is Tamara McCants. I wholeheartedly agree with what Ishay said about the virtual and in-person options and just making dual modalities, several modalities, so that people can access it whenever they want to. And even taking it a step further and making like
Mm,
self-paced options available, which could be as simple as a printed book or as fancy as, a voiceover webinar. But I wanted to go back to the goal for the program year. Just almost like asking a historical perspective, like how long has the program been in existence? What did the program think that was accomplished last year? And is there something that, looking at the overall perspective of the program, that you didn't think that you quite hit the mark?
Mm-hmm.
Or, as we consider what the goal will be for the upcoming year?
Yep. Yeah, I can answer that. So we're in year 2 of this iteration of our diabetes prevention program. They're 5 years, so we're just completing year 2 of 5. And we didn't touch on it much in the overview of the landscape assessment, but it is something that I want to note. So individuals really only spend around 1% of their lives in engaging with the hospital or clinical system. The other 99%, it's critical to the prevention and management of chronic conditions like diabetes. And so that's why we're so invested in ensuring that people have are aware of, have access to, and are using evidence-based education and training that supports their self-efficacy, their ability to self-manage and prevent and self-manage diabetes. That said, as we rolled out the landscape assessment, it was often challenging to get in contact with programs to find the right person within the organization that was leading the program. And so, if it was that difficult for us, I can only imagine that it's exponentially difficult for a resident and or a patient. And when you're working with a population that has multiple competing priorities, we really have to limit as much friction as possible to getting to and using these services and programs. And so really a major finding this year was, and this was from our work in diabetes, but also in cardiovascular, is that individuals are just not aware of what's out there. And when they are aware of what's out there, they're not sure how to get into it. And then when individuals get into the programs, there are sometimes challenges that are not challenges to completing that we're not maybe not identifying and addressing. So I think there's a big health literacy component, individual health literacy component. I think there's an organizational health literacy component or gap. Again, to making programs visible, accessible, and feasible to complete. Does that help?
Yes, it does, very much so. So to me, it sounds like the goal should be either increasing the number of participants or almost like a marketing plan, to increase the awareness of the programs.
Tyler, can you go back to the slide on the goal, please? Or Mariana?
Yes.
Yeah. Yeah, we can. Yeah. These are the four goals. Absolutely want this group's feedback on how to strengthen these. If you want to add or remove, replace. So Dr. McCann, just based on your input just now, is there a goal that you'd like to add here or modify one of the existing ones?
And I'm sorry, I feel like I'm talking so much and I came mad
No,
late.
no.
But so I think that number 4 supports number 2, and it's not really a goal in and of itself, to be honest. I actually feel like and I also think that number 3 is also like a subset of number 2. And maybe like 2 seems to me like the overall goal, with 1, 3, and 4. 1 and 3 serving as objectives of the overall goal, and then like 4 can also be an objective.
I like that. I like where your mind's going. Any other thoughts on that from the group? Now, this is the space to ultimately serve you all. So we want, we want to make sure that it reflects what you want to get out of it. So thank you.
If nothing else, I would just second the things that Dr. McCann said. I agree with her thought that 3 is a subset of 2. Yeah, everything that she said, I would agree with. That's the main reason why I don't really have too much to say about the goals.
Okay, that sounds good.
Okay.
Anyone else? Or is are others in agreement with that suggested modification? Anita, Andrea?
I'm fine. I got to jump onto another meeting. Thank you so much
No
for this
problem.
today. I appreciate
All right.
everyone.
Thank you. Thank you.
Thank you.
I agree. It looks good to me as well.
All right, thanks. All right, well, thank you all so much. Thank you, Andrea, for adding us. And so we're going to take back everything that we discussed today. send out process it all, send out some updates to the curriculum and goals for the community of practice. As we send that out, we would love to get your input on suggested speakers and subject matter experts. We have some ideas on our end, but want to get your input. And so keep an eye out for that. That'll be coming shortly. We absolutely value you all and your commitment to ensuring that our residents have the access to these tools that they need to live healthier, fulfilling lives. Our goal is to prevent diabetes where possible, certainly prevent complications from diabetes. And so we're so thankful for your partnership in that work. We'll be in touch shortly.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you.
Bye.